Today we're going to be talking about the use of ultrasound for chronic pain procedures. Ultrasound has traditionally been used in regional anesthesia and acute pain, but there is greater uses in chronic pain environments as well that we can explore today. One of the problems with traditional ways of doing chronic pain procedures is there's a lot of anatomic variation between patients, and this creates the opportunity for failure. In addition, the equipment that's used for chronic pain procedures can be expensive and often difficult to acquire. CT guidance, fluoroscopic guidance are high-tech equipment that requires special training and requires a large suite to operate in. Plus, there's the added risk of radiation to the provider over the long term with increased use of fluoroscopic equipment. Why ultrasound then? Well, ultrasound is now become a very portable piece of equipment. It's less expensive and it's user-friendly. There's no radiation with ultrasound, so we can use it in our patients and with ourselves without that risk over the long term. Ultrasound provides real-time visualization, just like fluoroscopy, but better than CT guidance, and allows us to see the variation in anatomy and pathology that we observe in our patients. When we're injecting medication, we can also see the spread of the injectate, which verifies the positioning of our needle, and it's very useful to confirm that final position before we do our injection. So what are some of the limitations of ultrasound? Well, it's very operator dependent. So there is a certain amount of skill set involved in learning the technology of the ultrasound and in the application of the anatomy and understanding of the anatomy when you're doing the procedures. The quality of the images in certain types of procedures can be poor, particularly in deep structures and with neuraxial and along the spine procedures, where the bone itself can obstruct the ultrasound imaging. And there is an added body of knowledge that's required, the anatomy of different parts of the body, but also the echogenicity and echotextures that come about when you observe this anatomy under ultrasound guidance. So how do we use ultrasound for chronic pain procedures? I'm going to give you a few examples today to demonstrate where ultrasound can be useful, where some of the limitations are, and how it has advantages over the traditional either surface anatomy, landmark approach, or fluoroscopic and CT guided approaches. First example is cervical epidural injections. With the ultrasound, there have been studies that show that you can actually increase the success rate of the epidural injection. And this is important because the epidural space in the cervical area is smaller and the anatomy can be quite variable. So increased success hopefully also leads to decreased complications. The complications in particular that we're worried about are dural punctures, arachnoiditis from injecting steroids in the intrathecal space, and then spinal cord injuries at the cervical level. How do you do the ultrasound guided procedure? Well, typically the procedures are done at the C6, C7 interspace, and that's because above this point the ligamentum flavum becomes less consistent in its anatomy, and this has an opening between the lamina that allows you access into the epidural space, whereas it becomes much tighter as you go up the cervical levels. We use a medium frequency linear ultrasound probe. This provides us enough depth with the ultrasound signal to see the anatomy we're interested in, but enough resolution to distinguish the various layers of interest. Typically when this procedure is done, the ultrasound is used to evaluate the depth to the epidural space, and it's measured using the calipers on the ultrasound equipment on a frozen image once the image is acquired. In addition, the optimal angle for needle puncture is measured on the frozen image. Once the procedure begins, a goniometer is used to fine-tune the needle insertion angle, and then a hanging drop technique can be used as the needle is advanced to initially verify that you've entered the epidural space and then confirm with a final loss of resistance to saline. One thing of note is when you measure with the ultrasound, you're often compressing the skin tissue, and so the depth from the skin to the epidural space on the ultrasound image is slightly less than the actual depth that you'll have to penetrate the tissue with using your needle, because of that compression is no longer there once the ultrasound is removed. In this image, you can see the transverse ultrasound image of the C6 level, and of note, there are a couple of anatomical landmarks that are useful to help identify where you are. First, the skin is up high, the muscles of the back come next, and then you see the dark shadow of the spinous process. Ultrasound doesn't penetrate bone, so it leaves a dark shadow behind it. The other dark shadow you see is the lamina on the sides, with a dark shadow behind it. Now, as you scan from caudal to cephalad and back and forth, you're looking for the gap in between the spinous processes where this shadow is less pronounced, and you can start seeing a window to the posterior complex of the spinal column. Now, this posterior complex is made up of the dura and the ligamentum flavum. Sometimes you can appreciate them as separate structures, but not always. But the highlight, the hyperechoic highlight that you'll observe of this posterior complex is the point that you want to measure to. So you can measure the angle from the skin to the posterior complex and the depth that the needle has to go. If you turn the ultrasound probe into a longitudinal view, you can appreciate the spinous processes at one point and then the next level down, and see the gap in between the spinous processes as your window. This is another way of viewing the posterior complex, where you can see the ligamentum flavum and the dura mater, and it allows you to evaluate your depth. Not as useful for determining the exact angle unless you're going on a midline approach to get to the epidural space. So, what are the challenges with ultrasound for cervical epidural injections? Because of the limitations of operating the ultrasound and driving your needle at the same time, it's not very easy to do this in real time. So typically you're using the ultrasound to measure your anatomy and measure your angle, but you're not actually driving the needle under direct visualizations, although there are some people attempting that currently. You can't visualize the spread of contrast like you can with fluoroscopy, and this is one of the reasons that some practitioners use this as the initial entry for the needle, but then use fluoroscopy to verify using a contrast medium as well. In the studies that were done with it, they actually did not observe a significant reduction in dural puncture, but what they did observe was an increased success rate and reduced time to complete the procedure. And generally, this is less invasive, faster. The ultrasound equipment by itself is more mobile and easier to handle than the larger equipment. Another example I want to give you is stellate ganglion injections. Now, stellate ganglion injections have been done with landmark approach and with fluoroscopic guidance for quite some time. The typical approach is a paratracheal approach where the needle is aimed towards the C6 anterior tubercle, and the injection with fluoroscopy is done with contrast to verify the spread in the correct plane, and then ultimately your local anesthetic or steroid. However, anatomically, the C6 level is closer to the middle cervical ganglion, and so this can produce inconsistent or sometimes failures in this block when you're trying to do this with landmark and fluoroscopic techniques. The variability in anatomy between one patient and another can also contribute to limitations in success rate. And the size and location of the tubercle can vary from patient to patient, with some anterior tubercles not actually blocking the vertebral artery. You increase the chance of vertebral artery puncture. And 10% of patients have a vertebral artery that's exposed even at the level of C6. If the injection spreads too posteriorly, you run the risk of a spinal root injection, and that can lead to an epidural spread and significant morbidity. Fluoroscopy does allow you to see the tubercle fairly well and allows for that variation of the anatomy. However, the tubercle again is just a surrogate marker. It doesn't give you any information of the exact tissue plane that you're interested in, and it doesn't give you good information about vascular and other soft tissue structures like the thyroid or esophagus that are in the vicinity. You want to generally try to avoid those structures to limit the damage to them. With ultrasound, the bone is not the target, and the target is the fascial plane and the prevertebral fascia. So you can visualize the spread under ultrasound guidance anterior and posterior to the fascia and verify that you have spread towards the stellate ganglion. You get a better sympathectomy, less recurrent laryngeal nerve spread, and you can improve your caudal spread towards the stellate ganglion and not just have it focused at the middle ganglion. With ultrasound, you use a linear probe. High frequency probes are preferred because you get a higher resolution. You don't need as much depth with this procedure as you do with the cervical epidural injection. You ultrasound at the level of the cricoid cartilage and use a transverse scan to visualize the anatomy in the area. The transverse process in the anterior tubercle of C6 can be visualized as, again, hyperechoic structures with a dark shadow behind it, as other bony structures often are. The longus colli muscle is visualized right in front of the anterior tubercle of C6, and then the prevertebral fascia is right in front of that. Other anatomy of interest in this area is the carotid artery and the thyroid gland. Using an in-plane approach, you can avoid many of the hazardous structures in this area and achieve the target to the prevertebral fascia in front of the longus colli muscle and deliver the injection correctly where you need to, again, not using the anterior tubercle as the target. In this image, you can see the ultrasound scanning plane, and you can observe that in the plane of view, you have your C6 vertebral body with the anterior tubercle. In front of it, you have the longus colli muscle and the prevertebral fascia. The thyroid gland sits in front of that, and the carotid artery is in this vicinity as well. So by visualizing this anatomy, you can find a path that avoids damaging those structures. So in this first example here, we see the highlight of the anterior tubercle of C6 and the longus colli muscle sitting in front of it. And this plane designated by the arrows here represents the prevertebral fascia. A traditional approach for your needle would involve the needle passing through this direction until you get to the anterior tubercle and injecting in this plane. However, as you observe on this ultrasound image, this requires passing through the thyroid gland, which can lead to vascular injury and thyroid gland tissue injury. Alternatively, under ultrasound guidance, after verifying Doppler flow to identify where the vessels are, a needle approach that comes in from a different angle can be achieved that gets to the prevertebral fascia without damaging these soft tissue structures and allows you to do an injection in the prevertebral fascia without damaging any of the thyroid, carotid artery, or other vascular structures in the area. Another category of ultrasound that can be used in chronic pain conditions is pelvic pain. Now, chronic pelvic pain comes in a variety of forms. Piriformis syndrome, border nerve syndrome, and pudendal are some of the common causes of chronic pelvic pain. Piriformis syndrome usually involves buttock and leg pain, and the management of this involves injection in the piriformis muscle itself, initially with local anesthetics and steroids, and then ultimately with botulinum toxin for long-term pain relief. Obviously, injection of these medications in an inappropriate area would produce less success and also potentially some harm to the patient. Now, of note, the piriformis muscle lies adjacent to the sciatic nerve, and the sciatic nerve typically lies underneath the piriformis muscle, but for almost 20% of the time, that relationship is not exactly the same, and the sciatic nerve can be split by the piriformis muscle or lie over top of it as well. And we don't want to be injecting in the sciatic nerve or around the sciatic nerve directly. We're more interested in the muscle. The existing techniques use CT guidance or fluoroscopy, and sometimes can use EMG or nerve stimulation to try to localize the piriformis muscle itself. What are the problems with this? Well, first, the EMG and CT scan can be difficult to obtain. It involves different personnel in a different suite and often is not available routinely for outpatient procedures. When you're using fluoroscopy, you're limited by the radiation again, and also the fluoroscopy shows you the bony structures in the area, in this case the sciatic notch, really well, but it doesn't show you the actual muscle itself until you inject contrast. And so you're guiding a needle to a surrogate marker, the sciatic notch, and waiting for injection of contrast to verify the position of the piriformis muscle itself. Nerve stimulator creates a new challenge. It can be used, but often these patients have very tender muscle tissue, and stimulating the muscle tissue throughout the process can cause undue discomfort to the patient. The ultrasound allows for direct visualization of the muscle tissue in the planes that are of interest to inject into. Real-time needle guidance allows the needle to be directed correctly in the right plane, and then confirmation of the injectate immediately in real time can be very useful before injecting more toxic substances and also limiting the amount of contrast that's necessary. There's no radiation involved, and actually it's fairly simple to learn once you've seen and observed this procedure a few times. How do you do the procedure? Well, you lay the patient prone. Typically we use a curved probe. This allows for a wide viewing angle, and also typically these are low frequency probes to give you depth of ultrasound imaging. You do a transverse scan over the level of the PSIS, and you view the SI joint and then pass laterally following the ilium. And what you're looking for is to see the muscle layers above the bony structures. The lowest, deepest layer will be the piriformis muscle, and then the gluteus maximus lies above that. The needle is typically advanced from the medial side towards the piriformis muscle in plane to the ultrasound beam. Once you achieve your target, you can actually put a nerve stimulator on it to confirm that it's piriformis muscle, but this is not always necessary. You want to inject between the gluteus maximus and the piriformis, or alternatively, directly inject into the muscle itself. Often patients experience pain relief instantaneously when using local anesthetics. This can be used for diagnosis, but it also can be useful for therapeutic benefit as well. In this image, you can see the ilium below, which creates that bright highlight like bone often does with dark shadowing behind it. And then the muscle layers above, piriformis muscle, seems as a mixed hyper and hypoechoic structure with a striated structure above it. That's the gluteus maximus. The needle is advanced from the medial side, advanced towards the bone, but it doesn't have to contact the bone itself. Once it enters the piriformis muscle, the injection can be done at that point. And this is a very quick procedure once you've practiced this several times. Another example of chronic pelvic pain is border nerve syndrome. And border nerve syndrome is caused by three major nerves: iliohypogastric, ilioinguinal, and genitofemoral nerves. And these supply the skin to the abdomen and the thigh. Now there is a risk of injury to these nerves from a variety of operations, and this is often the cause of these chronic pain conditions for patients. Fan and steel incisions for C-sections, appendectomies, inguinal herniorrhaphies, and trocars from laparoscopic surgery. Often these can be debilitating pain conditions, and simple injections can lead to diagnosis and sometimes treatment of these pain conditions. These nerves follow along from the lumbar plexus and travel around the side of the abdominal wall. The genitofemoral actually is a branch from the femoral nerve and follows along the spermatic cord in the inguinal ligament. Just as one example, I'll show you a technique for anesthetizing the ilioinguinal and iliohypogastric nerves as they penetrate through the abdominal wall, and how ultrasound can be beneficial for that. Traditional landmark approaches can be confusing. There's a variety of landmark approaches that have been described. They all use the ASIS as one of the landmarks, but there's a variety of measurements from that point that are used to describe where the injection should go. At the end of the day, it's an inaccurate injection, and when you're injecting more toxic substances, this can be a problem. There's a variability in anatomy between structures, and the multiple landmark approach creates confusion for how to best do this procedure. The success rate is always a problem as well with these blind techniques. With the ultrasound, you use a high frequency linear probe because these are superficial structures. The lateral end of the probe is placed just above the ASIS, and the ultrasound is oriented in a sagittal plane. The probe is perpendicular to the inguinal ligament, and it allows you to visualize the three abdominal muscle layers: the transversus abdominis, internal oblique, and the external oblique. You may also be able to visualize the peritoneum deep to the transversus abdominis. The needle is driven into the layer between the transversus abdominis and the internal oblique because both of the nerves pass through this layer at about that level. You can use stimulation if necessary to verify that you're getting paresthesia sensation in the groin area, but it's not necessary. And then the injection of local anesthetic, with or without steroid, can be done in that plane. Some people also refer to this block as a TAP block because it's the transversus abdominis plane block, and is often used in acute pain and regional scenarios as well. In this image, you can see the peritoneum deep and the ASIS as the reference point, and you have three layers above that: the transversus abdominis, the striated muscle, with a fascial plane separating that in the internal oblique, another fascial plane, and the external oblique lying on top of that. These layers are easy to visualize because they have distinct fascial separations between them. The nerves pass through this layer between the transversus abdominis and the internal oblique, and the needle can be driven into the layer and inject local anesthetic and or steroid into that space. And you can see expansion of that space to verify that you've injected into the correct plane. Again, very easy to do, very simple, doesn't require a lot of discomfort on the patient's part. Lastly, in the category of chronic pelvic pain conditions is pudendal neuralgia. This is a chronic debilitating pain that some patients can experience in their penis, scrotum, labia, or perineum, or anal rectal region. And this often occurs because entrapment of the pudendal nerve occurs between the sacrotuberous and sacrospinous ligaments. A pudendal nerve block can be very diagnostic and sometimes even therapeutic for these patients. The anatomy in this area is the pudendal nerve emerges from the sacral foramen. It's accompanied by the internal pudendal artery, which is really critical to ultrasound technique because you use that as a landmark to help determine where the nerve is. And it exits the pelvis through the greater sciatic notch, passes between those two ligaments, and then swings anterior to come to the perineal region. The existing techniques are complicated. The interligamentous plane is key for the needle localization. However, CT allows for this visualization of this plane. CT is not always readily available, and it doesn't provide the real-time information that we're often interested in. Fluoroscopy provides real-time information, but you can't see the ligamentous plane. You can only see the ischial spine and use that as a surrogate landmark, which isn't always as precise as we would like to see. With ultrasound, you can visualize all the important landmarks in that area: the ischial spine, the pudendal artery, sacrospinous ligament, sacrotuberous ligament, and the pudendal nerve itself. And using the combination of these structures, you can locate the exact area of injection, real-time visualization of the needle, and real-time confirmation of the injectate spreading between those interligamentous planes. A low-frequency probe is useful here. Again, you're looking at deeper structures, so low-frequency probes are useful. And you scan transversely above the ischium and the lateral border of the notch. Color Doppler flow is useful to identify the pudendal artery, and you know that the nerve lies adjacent to the pudendal artery. Once the artery is identified, you can identify the sacrospinous and sacrotuberous ligaments and identify the pudendal nerve in between these ligaments. Often the nerve is not visualized directly, but the ligaments and the artery can be visualized to identify the plane. The needle is advanced in plane from the medial side towards the internal pudendal artery, and then the injectate helps open up those planes so that you can identify the structures further and identify the nerve lying in between those ligaments. Nerve stimulation can be useful as a negative test to make sure that you're not injecting at the sciatic nerve, which is nearby. We don't want to numb up the patient's entire leg. We're just trying to target this one nerve. In this image, you can see the ischial spine, again, a bright highlight with dark shadow behind it. And with the color flow Doppler, you can see the artery is identified on color imaging. Once the artery is identified, the needle can be advanced towards the artery, and you can see the sacrotuberous and sacrospinous ligaments are more hyperechoic than the tissue around it. And once the injectate enters into the space between here, they become more distinct, and the nerve becomes distinct as well, lying in this plane. Again, fairly easy to do. Once you identify the anatomy, driving the needle to the space is quick and relatively painless. There are a variety of other uses of ultrasound for chronic pain. This is briefly a sample of those things. Suprascapular nerve blocks, intercostal nerve blocks, any of the peripheral nerve blocks that are used for acute pain can be used to help diagnose and treat chronic pain conditions in those areas. So these ultrasound can be used in a variety of these conditions, limiting the radiation and making it more accessible to more patients because we don't require high-tech equipment, we don't require the same amount of space that fluoroscopy and CT require. One other example I want to give you before closing is intrathecal pump refills. Obviously, we're injecting high concentration medications into these intrathecal pumps, and we want to make sure that we inject that properly. Using the ultrasound, you can identify the injection diaphragm and make sure that the needle enters the diaphragm at the appropriate level so that you can provide only one stick and have success with that one stick when you're refilling your intrathecal pumps. So in closing, I think ultrasound can be a very useful technique in chronic pain conditions and often can be combined with fluoroscopy or CT guidance to enhance the ability to visualize soft tissue structures, to visualize the spread of the injectate, and provide an alternative method when fluoroscopy and CT are not available. Thank you.